Damage control surgery, Q&A. Welcome to today's episode, where we will be diving deep into the core concepts, phases, and practical nuances of damage control surgery. This podcast is designed for surgical residents and clinicians seeking a thorough understanding of this life-saving approach. Let us explore the topics in a structured question and answer format. Pause the video after each question to attempt the answer. Let's begin. Core principles and indications question. What is the fundamental philosophy of damage control surgery? Answer. The fundamental philosophy of damage control surgery is to prioritize patient survival over anatomical reconstruction. This means abandoning the traditional goal of a single, definitive operation for a critically injured patient and adopting a staged approach. The three stages are: first, control of hemorrhage and contamination; second, resuscitation in the intensive care unit; and third, delayed definitive repair. Question. What is the overarching physiological goal of damage control surgery? Answer. The overarching physiological goal is to reverse the so-called lethal triad of trauma, which consists of hypothermia, acidosis, and coagulopathy. Question. Define the lethal triad of trauma. Answer. The lethal triad is a self-perpetuating cycle involving hypothermia, defined as a core temperature less than 35 degrees Celsius which impairs coagulation enzyme function and platelet activity; acidosis, defined as a pH less than 7.2, which reduces cardiac contractility and responsiveness to catecholamines; and coagulopathy, which is clotting failure due to factor consumption, dilution, and dysfunction. Question. What are the primary indications for initiating a damage control approach? Answer. The primary indications are signs of physiological exhaustion rather than just injury patterns. These indicators include a core temperature less than 35 degrees Celsius, a pH less than 7.2, a base deficit greater than -15 milliequivalents per liter, transfusion requirements exceeding 10 units of packed red blood cells in 24 hours or more than 4 units per hour, non-mechanical oozing bleeding, and an international normalized ratio greater than 1.5. Question. What are some high-risk injury patterns that should prompt consideration of damage control surgery? Answer. High-risk injury patterns include major multicavitary trauma, destructive pancreaticoduodenal injuries, complex hepatic injuries involving juxtahepatic veins, and severe pelvic fractures with ongoing hemorrhage. Question. Who makes the decision to initiate damage control surgery? Answer. The decision should be made preemptively by the most senior surgeon present, based on the patient's physiological status and injury burden, and not as a last resort. Question. What is the single most important factor in determining survival in damage control surgery? Answer. Early decision-making is the most critical factor. Initiating damage control surgery before the lethal triad becomes irreversible greatly increases the chances of survival. Question. How does hypothermia contribute to coagulopathy? Answer. Hypothermia slows the enzymatic cascade involved in clotting and impairs platelet function, which compromises the body's ability to stop bleeding. Question. How does acidosis contribute to coagulopathy? Answer. Acidosis reduces the activity of essential enzyme complexes necessary for clot formation, such as tenase and prothrombinase. Question. What is the bloody vicious cycle? Answer. The bloody vicious cycle is another term for the lethal triad, emphasizing how hypothermia, acidosis, and coagulopathy feed into and exacerbate one another. Phase 1. The initial laparotomy and techniques question. What is the primary goal of the initial damage control surgery laparotomy? Answer. The primary goal is control of hemorrhage. Stopping bleeding takes precedence over all other considerations. Question. What is the secondary goal of the initial damage control surgery laparotomy? Answer. The secondary goal is control of contamination, especially from hollow organ injuries such as bowel perforations. Question. What are the 4 key techniques for controlling hemorrhage in damage control surgery? Answer. The 4 key techniques are packing, temporary shunting, ligation of vessels, and resection without anastomosis. Question. How is perihepatic packing performed? Answer. Perihepatic packing involves placing surgical packs above, below, and behind the liver to tamponade bleeding, compressing it against the diaphragm and retroperitoneum without occluding the inferior vena cava. Question. What is a Pringle maneuver? Answer. A Pringle maneuver involves compression or clamping of the hepatoduodenal ligament to control inflow bleeding from the hepatic artery and portal vein. Question. When should you consider a retrohepatic venous injury? Answer. A retrohepatic venous injury should be considered when bleeding from behind the liver persists after applying a Pringle maneuver, which suggests injury to the hepatic veins or inferior vena cava. Question. What is the best approach to a retrohepatic venous injury in damage control surgery? Answer. The best approach is packing, as attempts at definitive repair are often fatal. Packing is successful in over 80% of cases. Question. How do you manage a major destructive pancreatic or duodenal injury in damage control surgery? Answer. Such injuries are managed by wide drainage, debridement of non-viable tissue, and control of duodenal contamination with a stapled off loop or ligation, deferring reconstruction for a later phase. Question. How is a splenic injury managed in damage control surgery? Answer. Splenic injuries are typically managed with rapid splenectomy. Question. How is a major renal injury managed in damage control surgery? Answer. In an unstable patient, rapid nephrectomy is performed to control hemorrhage. Question. How are major vascular injuries of the abdomen and extremities managed in damage control surgery? Answer. Temporary intravascular shunts are used to restore blood flow, allowing for delayed definitive repair. Question. How are hollow organ injuries managed in damage control surgery? Answer. Contamination is controlled by rapid stapling or ligation of the injured segment, leaving bowel ends in discontinuity without immediate anastomosis or stoma creation. Question. What is the Bogota bag? Answer. The Bogota bag refers to a sterile 3-liter irrigation bag or a commercially available device used for temporary abdominal closure. Question. What is the purpose of the temporary abdominal closure? Answer. The temporary abdominal closure protects abdominal contents, prevents evisceration, allows fluid egress to prevent abdominal compartment syndrome, and facilitates easy re-entry. Question. Name 3 commercially available systems for temporary abdominal closure. Answer. These include the Obthera system, Barker's vacuum pack technique, and Whitman patch. Question. What are the advantages of negative pressure wound therapy for temporary abdominal closure? Answer. Negative pressure wound therapy removes edema fluid, reduces bacterial count, may facilitate fascial closure, and is easy to manage. Question. How long should the initial damage control surgery operation ideally take? Answer. The initial operation should take less than 60 to 90 minutes, with speed being essential. Question. What is damage control thoracotomy? Answer. Damage control thoracotomy applies the same principles to the chest, using clamps, packing, or staplers for bleeding control, temporary closure, and rapid transfer to the intensive care unit. Question. When is thoracic aortic cross-clamping used? Answer. Thoracic aortic cross-clamping is a last resort for maximizing cerebral and coronary perfusion in profound hemorrhagic shock or controlling massive intra-abdominal hemorrhage below the diaphragm. Question. What is resuscitative endovascular balloon occlusion of the aorta and how does it relate to damage control surgery? Answer. Resuscitative endovascular balloon occlusion of the aorta is a less invasive alternative to aortic cross-clamping for temporary proximal hemorrhage control in the abdominal or pelvic regions. Phase 2. Intensive care unit resuscitation. Question. What is the primary goal of Phase 2? Answer. The goal of Phase 2 is to complete resuscitation, reverse the lethal triad, and optimize the patient's physiology for return to the operating room. Question. What is the target core temperature? Answer. The target is a core temperature above 36 degrees Celsius, achieved with forced air warmers, warmed fluids and blood, and a raised ambient temperature. Question. How is acidosis corrected? Answer. Acidosis is corrected primarily by restoring perfusion with adequate fluid and blood product resuscitation. Sodium bicarbonate is used only for severe, refractory acidosis. Question. What is the goal of hemodynamic resuscitation? Answer. The goal is to achieve adequate end organ perfusion, as measured by normalization of lactate, base deficit, and urine output greater than 0.5 milliliters per kilogram per hour. Question. What is the preferred resuscitation fluid in damage control surgery? Answer. Warm blood products in a balanced ratio of packed red blood cells, plasma, and platelets, following a massive transfusion protocol. Question. What is a massive transfusion protocol? Answer. A massive transfusion protocol is a pre-established system for rapid delivery of large volumes of blood products in a balanced ratio to prevent or treat coagulopathy. Question. Why is a 1:1:1 ratio of blood products advocated? Answer. This ratio closely approximates whole blood, helping to correct coagulopathy by replacing clotting factors and platelets lost through hemorrhage and dilution. Question: what is goal-directed therapy in phase 2? Answer: goal-directed therapy uses parameters like stroke volume variation, cardiac output, and systemic vascular resistance to guide fluid and vasopressor therapy. Question: when are vasopressors indicated? Answer: vasopressors are indicated only after adequate volume resuscitation has been achieved and hypotension persists due to low systemic vascular resistance, and they are not a substitute for volume replacement. Question: what is abdominal compartment syndrome? Answer: abdominal compartment syndrome is a sustained intra-abdominal pressure greater than 20 mm of mercury accompanied by new organ dysfunction or failure. Question: how is intra-abdominal pressure measured? Answer: intra-abdominal pressure is measured via the bladder by instilling saline and transducing the pressure at end expiration. Question: what are the clinical signs of abdominal compartment syndrome? Answer: signs include a tense abdomen, high peak airway pressures, reduced urine output, and hypotension refractory to fluid resuscitation. Question: how is abdominal compartment syndrome treated? Answer: it is treated by decompressive laparotomy, which is a surgical emergency. Question: what is the role of thrombolistography or rotational thrombolistometry? Answer: these tests provide dynamic whole blood assessments of coagulation and fibrinolysis, enabling targeted transfusion of specific blood products. Question: when should the patient return to the operating room for phase 3? Answer: the patient should return when the lethal triad has been reversed, which is typically 24 to 72 hours later. Question: what is the biggest risk of waiting too long for reoperation? Answer: delaying reoperation can lead to recurrent abdominal compartment syndrome, enteric fistulas, and intra-abdominal sepsis. Phase 3, definitive surgery and reconstruction. Question: what is the goal of the first relook operation in phase 3? Answer: the goal is to remove surgical packs, perform a thorough exploration, restore intestinal continuity, and decide on the definitive closure plan. Question: what is the first step upon re-entering the abdomen? Answer: the first step is careful removal of all packs, being prepared for potential rebleeding. Question: how is bowel continuity restored? Answer: bowel continuity is restored with delayed anastomosis, such as stapled or hand-sewn connections between segments. Question: when is a stoma preferred over an anastomosis in phase 3? Answer: a stoma is preferred in high-risk situations, such as persistent hemodynamic instability, ongoing vasopressor requirement, gross fecal contamination, or questionable bowel viability. Question: how are complex liver injuries managed in phase 3? Answer: formal liver resection is rarely required. The main steps are pack removal, debridement of devitalized tissue, and ensuring adequate drainage. Question: how are pancreatic injuries definitively managed? Answer: distal pancreatic injuries are managed with distal pancreatectomy, often with splenectomy. Central or proximal injuries may require complex drainage or delayed reconstruction. Question: how are vascular injuries definitively managed? Answer: temporary shunts are removed and definitive repair is performed, such as vein patching, interposition grafts, or permanent bypass. Question: what is the preferred method for definitive abdominal closure? Answer: primary fascial closure is the preferred method whenever possible. Question: what if the fascia cannot be closed primarily due to edema or loss of domain? Answer: staged closure techniques are used, such as a planned ventral hernia with skin grafting or mesh-mediated gradual fascial closure. Question: what is a component separation technique? Answer: component separation is a surgical technique to mobilize the abdominal wall muscles, facilitating tension-free primary fascial closure, often used in later reconstruction. Question: what is the role of biological mesh in damage control surgery? Answer: biological mesh provides a scaffold for fascial healing in contaminated fields where synthetic mesh is contraindicated. Question: what are the potential complications after damage control surgery? Answer: complications include enteric fistulas, intra-abdominal abscesses, necrotizing soft tissue infections, abdominal compartment syndrome, venous thromboembolism, and prolonged intensive care unit stay with related complications. Question: what is the most common source of an enterocutaneous fistula? Answer: the most common source is exposed bowel anastomosis or injured bowel that was either missed or becomes ischemic under surgical packs. Question: how is a fistula managed initially? Answer: Management includes output control with vacuum dressings, skin protection, nutritional optimization often with total parenteral nutrition, and sepsis control, with operative repair delayed for 6 to 12 months. Advanced and specific scenarios. Question: how does damage control surgery apply to non-trauma patients? Answer: the principles apply to any patient with life-threatening surgical pathology and physiological exhaustion, such as necrotizing pancreatitis with hemorrhage or mesenteric ischemia with bowel necrosis and shock. Question: what is damage control orthopedics? Answer: damage control orthopedics involves stabilizing long bone fractures with external fixators instead of lengthy procedures in unstable polytrauma patients to avoid excessive physiological stress. Question: what is the second hit theory? Answer: the second hit theory describes how an initial traumatic insult primes the immune system, and a subsequent stressor can trigger an exaggerated inflammatory response and organ failure. Question: how does damage control surgery mitigate the second hit? Answer: by keeping the initial operation short and life-saving, delaying major reconstruction until the patient is stabilized. Question: what is the role of tranexamic acid in damage control surgery? Answer: tranexamic acid is an antifibrinolytic agent most effective if given within 3 hours of injury in patients with significant hemorrhage or signs of hyperfibrinolysis. Question: how should a severe pelvic fracture with hemorrhage be managed in damage control surgery? Answer: management includes application of a pelvic binder or sheet, angioembolization, external fixation, and preperitoneal packing. Question: when is preperitoneal packing indicated? Answer: preperitoneal packing is indicated for unstable pelvic fractures when transfer to angiography is delayed or unavailable. Packs are placed directly on fracture sites to tamponade venous bleeding. Question: what is the role of resuscitative endovascular balloon occlusion of the aorta in pelvic fracture hemorrhage? Answer: use of resuscitative endovascular balloon occlusion of the aorta in Zone 3 provides temporary inflow control for resuscitation and definitive control. Question: how is a retroperitoneal hematoma managed in damage control surgery? Answer: retroperitoneal hematomas should not be opened unless expanding, pulsatile, or associated with a penetrating injury, as the retroperitoneum offers natural tamponade. Question: what are the key principles of damage control surgery in pediatric trauma? Answer: the same principles apply, though children have greater physiological reserve but less tolerance for hypothermia and hypovolemia. Blood product ratios must be weight adjusted. Complications and pitfalls. Question: what is the most common cause of death after successful damage control surgery? Answer: the most common cause of death is late-onset multiple organ failure due to persistent inflammation. Question: why is enteral nutrition important after damage control surgery? Answer: enteral nutrition maintains gut barrier function and prevents bacterial translocation, which can lead to sepsis and multiple organ failure. It should be started early if possible. Question: what is the risk of intra-abdominal hypertension after initial closure? Answer: the risk is high, and intra-abdominal hypertension can progress to abdominal compartment syndrome, requiring ongoing monitoring. Question: what is the open abdomen and what are its consequences? Answer: an open abdomen is one deliberately left open post-laparotomy. Consequences include massive fluid and protein loss, fistula formation, and a planned ventral hernia. Question: how is a high-output enterocutaneous fistula managed? Answer: management requires expert wound care, nutritional support often with total parenteral nutrition, use of somatostatin analogs, and delayed surgical repair. Question: what is the role of prophylactic antibiotics in the open abdomen? Answer: prophylactic antibiotics are not indicated for the open abdomen itself and are only used for specific infections or reoperations. Prolonged use leads to resistant organisms. Question: what is the most common organism found in intra-abdominal infections after damage control surgery? Answer: the most common organisms are nosocomial pathogens such as Candida, methicillin-resistant Staphylococcus aureus, and multi-drug-resistant gram-negative rods. Question: why is venous thromboembolism prophylaxis critical in these patients? Answer: patients are hypercoagulable after resuscitation and immobilized. Sequential compression devices and chemoprophylaxis are recommended as soon as bleeding risk is acceptable. Question: what is the significance of a persistently high lactate after phase 2? Answer: Persistently high lactate indicates ongoing hypoperfusion or sepsis and is a poor prognostic sign that must be investigated. Question: when should you consider a second look operation even if the patient is not perfectly optimized? Answer: a second look operation should be considered if there is suspicion of bowel ischemia or an undrained septic focus. Miscellaneous and practical pearls. Question: what is the most common error in damage control surgery? Answer: the most common error is delaying the decision to convert to damage control surgery. Early transition is crucial. Question: how should the operating room be prepared for a potential damage control surgery case? Answer: preparation includes warming the room, having a rapid infuser ready, activating the massive transfusion protocol, and ensuring all necessary surgical materials are available. Question: what is the role of the anesthesiologist in damage control surgery? Answer: the anesthesiologist is responsible for intraoperative resuscitation, managing the massive transfusion protocol, correcting coagulopathy, and warming the patient. Question: name a key communication tip between surgeon and anesthesiologist during damage control surgery. Answer: frequent updates regarding estimated blood loss, surgical progress, and the operative plan are essential. Question: what is the damage control mindset for a major peripheral vascular injury? Answer: the approach is to shunt the vessel, perform fasciotomies to prevent compartment syndrome, and provide temporary closure, with definitive repair later. Question: why are fasciotomies important in extremity trauma with vascular injury? Answer: fasciotomies prevent compartment syndrome, which can lead to limb loss, particularly after reperfusion following ischemia. Question: how is a destructive colon injury managed in the definitive phase if the patient remains unstable? Answer: management involves creating an end colostomy, as a diverting loop colostomy is inadequate for truly destructive injuries. Question: what is the role of laparoscopy in damage control surgery? Answer: laparoscopy has a minimal role in the acute phase but may be useful for diagnosis or washout in stable patients during later stages. Question: how do you manage a patient with a persistent open abdomen after weeks? Answer: if primary closure is impossible, the wound is allowed to granulate and a split-thickness skin graft is placed over the bowel, resulting in a planned ventral hernia for later repair. Question: what is the take-home message about nutrition in damage control surgery patients? Answer: the gastrointestinal tract should be used for nutrition if possible. If enteral feeding is not tolerated, early total parenteral nutrition should be considered. Question: what is the role of Factor 7A in damage control surgery? Answer: Factor 7A is a potent agent for severe coagulopathy and is used as a rescue therapy only after other measures have been addressed. Question: how should hypothermia be actively corrected in the intensive care unit? Answer: hypothermia is corrected with forced air warming blankets, warmed intravenous fluids, humidified air, and, in severe cases, intravascular warming catheters. Question: what is the significance of a low fibrinogen level? Answer: fibrinogen is vital for clot formation, and levels below 150 to 200 mg per deciliter should be treated with cryoprecipitate or fibrinogen concentrate. Question: what is the most critical nursing consideration in the intensive care unit for a damage control surgery patient? Answer: critical considerations include meticulous monitoring of vital signs, intra-abdominal pressure, fluid balance, and abdominal dressings for signs of bleeding or infection. Question: how does damage control surgery impact long-term quality of life? Answer: patients face extended recovery with risks of disability, chronic pain, and psychological effects, but the approach saves lives that would otherwise be lost. Question: what is the key difference between damage control surgery and a bailout procedure? Answer: damage control surgery is a planned and deliberate strategy, while a bailout is a desperate move after failed definitive surgery, often undertaken too late. Question: when should you consider leaving the abdomen open after an elective case? Answer: the abdomen may be left open in non-trauma cases with profound physiological derangement, risk of abdominal compartment syndrome, or need for a second look operation. Question: what is the damage control approach to a bleeding duodenal ulcer in an unstable patient? Answer: the approach includes oversewing the ulcer, performing a pyloroplasty, and highly selective vagotomy for rapid control, avoiding complex resection. Question: what is the role of interventional radiology in damage control surgery? Answer: interventional radiology, particularly angioembolization, is essential for controlling arterial bleeding in solid organs and the pelvis, both after initial damage control surgery and as a primary modality. Question: what is the ultimate measure of success in damage control surgery? Answer: the ultimate measure is patient survival from injuries previously uniformly fatal. Achieving definitive fascial closure is a secondary but important milestone. Thank you for tuning into this comprehensive Q&A podcast on damage control surgery. Stay informed, stay prepared, and always prioritize patient physiology and survival. If you enjoy the content, please like, share, and subscribe. It's the Everything Surgery Podcast. Dissect the extraordinary.